Hello and welcome to this Ausmed lecture on the basics of invasive ventilation. My name's Tony King. I'm a clinical nurse educator in intensive care. What we're going to look at today is the terminology, some of the basic principles for invasive ventilation, and finally setting up a patient on a ventilator. There are three main reasons we would intubate, so putting a breathing tube in somebody and then ultimately ventilate them. That's for airway protection, so if they're unconscious. A general rule of thumb is this GCS less than 8, you intubate. There's always exceptions to those rules, but that's a good general rule to work off. If there's particular airway trauma that we want to secure the airway before that swelling gets worse, or particular things like smoke inhalation injury. Another reason would be for ventilatory failure, so type 1 for low oxygen, or type 2 high carbon dioxide levels. And the third one is to facilitate something else. So if there's major surgery that needs to take place, or they're critically unwell. When we have ventilated somebody or intubated them and put them on a ventilator, there are some basic principles we need to abide by, and we want to deliver the lowest amount of oxygen possible. Flooding the system with oxygen is not such a good thing. We aim to reduce the work of breathing for the patient. We want to control their arterial carbon dioxide, and in doing so, we control their pH so the body can function normally. And ultimately, what we want to do, no harm. So we want to avoid high pressures in ventilation. And as soon as we don't need that person to be ventilated anymore, we want to wake them up and get that breathing tube out. In order to deliver invasive ventilation, we need to create a closed circuit. To do that, we put a breathing tube into the airway. Those breathing tubes have cuffs or balloons on the end of them. And with that cuff being blown up, we create a seal, and that's called the closed circuit. And that's how we deliver intubation. I think terminology is the thing that confuses people most when it comes to ventilation. And we're just going to go through 2 slides of terminology, and that's covering the basics of terminology around ventilation. I think the biggest confusing thing is that there's multiple names for everything here. So PEEP, positive end expiratory pressure, is the invasive term, but for non-invasive ventilation, it's called CPAP, EPAP. They're all basically the same thing. It's a positive continuous pressure applied throughout the breath, the entire breath cycle. What that does is it splints open the alveoli, it splints open the airways, and if it was non-invasive, it's splinting open the upper airway as well and displacing some of that tissue. So in doing that, it holds those alveoli open and they can take part in gas exchange, particularly useful for oxygen exchange. Breath delivery, we'll come back to these terms quite a bit in the next little while, but we have mandatory breaths or spontaneous breaths. A mandatory breath is delivered by the ventilator. You set that as the operator. A spontaneous breath, the person is triggering that. So that's the patient in charge of their own respiratory rate, like you and I are right now. Then we have volume or pressure delivery. Volume, we're setting a volume on the ventilator. In pressure, we're setting a pressure. Okay. Rate is fairly self-explanatory, but important to note that we're only worried about rate in a mandatory mode where you are setting the rate for the patient. Inspiratory pressure, so if PEEP was that positive pressure applied through the whole breath, inspiratory pressure is the pressure being applied through inspiration in the inspiratory phase of the breath. Peak pressure is that maximum pressure that's reached during inspiration. Plateau pressure can sometimes be a bit tricky, but just think once the peak pressure is reached, there's a brief moment where that pressure settles across the whole lung field. And once that pressure is settled, that's called the plateau pressure. So it's a very brief period after the peak inspiratory pressure. That's the pressure we most worry about causing damage to the lungs. That if we have really high plateau pressures being applied across the entire lung field and the alveoli, that's when we can do some damage. And pressure support is for those spontaneous breaths. And we'll come back to some of these terms as we go along. But that's the amount of pressure supporting the person on inspiration when they want their own breath. Cycle is an important thing to wrap our heads around. Cycle is all about how does the breath start, how does the breath stop. Okay. So in a mandatory mode, we set the rate. Let's just stick with simple maths. So if you set a rate of 10, you have 60 seconds divided by 10. Every 6 seconds, a breath will be delivered. So every 6 seconds on cycle, the ventilator will deliver a breath. How does it stop the breath is determined by what mode you're in. Triggering, Well, in a mandatory mode, the triggering is time. So again, if you've got 10 breaths a minute, that's 6 seconds. Every 6 seconds, the ventilator is triggered to deliver a breath. In a spontaneous mode, the patient triggers the breath. Okay, so they either draw some breath out of the circuit or they drop some pressure in the circuit by drawing breath. Flow, gas flow, depending on what ventilator you're using, you can set that or it can be automatically managed by the ventilator. The peak flow is the maximum amount of gas being pushed through by the ventilator at any one time. Okay, so you and I right now are probably drawing in about 40 to 60 litres a minute of flow, of gas flow. But when people get really, really unwell or, high athletes exercising really hard, they can get up to 90, 100 plus litres a minute of gas flow. So we just need to be conscious of that when we're ventilating people, particularly if they're working really hard or they're really unwell. Minute volume, that's how we control our patient's arterial pressure of carbon dioxide and in turn their pH. That's your respiratory rate times your tidal volume. Gives you your minute volume or minute ventilation. Again, terminology, there's multiple names for the same thing, which is why it's so confusing. FiO2, I'm sure we're familiar with. That's just the oxygen. And there's many, many more, but we're covering some basics of ventilation today. If we kind of represent what we just talked about in a slightly different way, we've got invasive positive pressure ventilation. Now, all invasive ventilation is positive pressure. Okay, we are using a ventilator to push and deliver gas into the person's lungs. We have mandatory modes, volume control or pressure control. So you're either setting a volume or a pressure, or we have spontaneous on the other side, and that's where the person is in control. The main two modes in spontaneous ventilation is pressure support, where we deliver a bit of pressure to help the person breathe. Remember, they're breathing through some piping, right? So that's adding extra resistance and a bit of hard, imagine breathing through a straw. So pressure support is designed to overcome some of that resistance. And there's a mode called automatic tube compensation, but essentially it's a fancier version of pressure control. And then in the middle, if we bridge both of those two things, a lot of what we're trying to do with invasive ventilation is ensure that we have good synchrony with the person. Okay, synchrony means that the person is not resisting being on a ventilator, that when they want to take a breath, if they're starting to wake up, they're allowed to take a breath. That's where SIMV comes into play. So this is synchronized, intermittent mandatory ventilation. So we have a mandatory component, but they've also got that spontaneous mode in the background if they are waking up and they do want to take a breath. You couldn't imagine waking up, being on a mandatory mode, wanting to take a breath, and you're just starved. You're kind of bucking against the tube. And we still see that even in SIMV. Now, those terms and those modes have lots of different variations, but if we can kind of wrap our heads around these basic modes, that will set you up for really good, in good stead for what may come around the corner in the next iteration of ventilator modes. We've talked that we've got volume or pressure for our mandatory modes. Which one do you choose? It doesn't really matter. Okay, there are a few rare exceptions, but on the whole, we're delivering one and we're monitoring the other. By far and above, the most common mode of ventilation would be volume control ventilation. We set that in a mils per kilo of ideal body weight. So we're aiming 6 to 8 mils per kilo. Really, we're aiming for 8 mils per kilo. So for the average person, 70 kilos, let's do 7 times 8 is 56. 560 mils is the tidal volume that we're going to set for that person. If you were to choose pressure control, you would be titrating your inspiratory pressure to still achieve that same goal of 560 mils. It's just that you're using pressure to get there. So that's what I mean by saying you're delivering one, but you're monitoring the other. If you're in pressure, you're making sure that you're still achieving the volume aim that you want for that person, that you're saying is a safe volume aim. If you're in a volume control mode and you're delivering, the ventilator is delivering to a set volume, you're still mindful that you're not delivering high pressures to the lungs, particularly high plateau pressures. So some basic physics. I'm not going to bore you with a whole lecture on physics, but when we're thinking about ventilation, we need to be conscious of some of our gas laws. One of the main ones is that the air is the sum of its parts. So we know that the air that we breathe is 21% oxygen, 78% nitrogen, and that remaining 1% is made up of things like CO2, water vapor, all those inert gases like argon and whatever. Temperature has an effect on gas. Cold, it will shrink. If it gets hotter, it expands. And the main one being that there is an inverse relationship between the size of a container and pressure. So if you have a given container and you expand it, you drop the pressure. If you shrink that container, you increase the pressure. If we're thinking about the container in ventilation, the container is your lungs and your airways. So if you shrink the size of the lung capacity by getting something like an infection, so a pneumonia, or a pleural effusion that is squishing the lungs and making the lungs smaller, and you're still trying to deliver the same volume of breath, you're going to increase the pressure. So there is a relationship between the size of a container and pressure, and that's something we need to be very conscious of in ventilation. So all of that said, let's talking about setting up a patient on a ventilator. So the first thing we need to make a decision on is the mode. Are we in a mandatory mode or a spontaneous mode? Let's just say we're in a mandatory mode, and that way we can talk about a few more of the settings. We're going to choose volume control because that is by far and above the most common mode of ventilation. And we're going to set a tidal volume of 8 mils per kilo. Okay. Rate. How do you set up a rate in the first place? Well, you're looking at the patient in front of you and looking at their carbon dioxide levels if you've measured that on a blood gas or if you've got the end-tidal CO2. But so often, particularly if you're going into theatre, you'll just be setting an arbitrary rate of about 12 or 14 breaths to start with. If you've got a really sick patient in front of you, you'll probably choose a higher starting breath rate of maybe 18 to 20 breaths. So you'll set a starting rate and you'll be moving that around once you start to get some feedback from your patient. Volume, 8 mils per kilo. I'm going to stick with our 70 kilo patient. So we're setting a tidal volume of 560 mils. Pressure support, that is there because we're going to be in an SIMV mode, okay? Very, very rarely do we set just a mandatory mode anymore. So we'll set SIMV, which means we have some pressure support settings there in case the person wakes up and they want to take a breath. Stock standard is about 10 of pressure support. We're going to set a PEEP. There's a whole thing about how do you set PEEP. You're meant to identify the lower inflection point and you set that 2 centimeters above. Again, we're talking basics of ventilation here. So 99% of your patients will be on 5 centimeters of water of PEEP, okay? The majority of us have a lower inflection point of about 2 or 3 centimeters, which is why we land on 5 centimeters of water. As patients get sicker or they have particular disease processes, you may want to use higher levels of PEEP. FiO2 is oxygen. You set oxygen exactly like you're used to setting oxygen for a patient right now, whether they're intubated or not. And trigger is about how does the ventilator interact with this person. So we're saying that we want the ventilator to synchronize with the patient. Triggering is, well, how does the ventilator know when that person wants a breath? Okay, it's going to be either a flow trigger or a pressure trigger. All that means is in a ventilator circuit, we have PEEP. There's a constant flow of gas. And if there's a flow of gas, there's a pressure within that circuit as well. The patient either draws some flow out of the circuit, and that's how the ventilator knows that they want a breath, or in drawing flow, they drop the pressure momentarily. And that the ventilator is watching for that, and that's how it knows the person wants a spontaneous breath. And when they trigger, they get pressure support, and that's a spontaneous breath. In invasive ventilation, we need to be very conscious about some of the things on this screen. So we need to be setting alarms. At the start of your shift, alarms are there to alert you, not to alarm you, okay? So we should be setting our alarms really, really narrow in range and call for help early, particularly if you're not that comfortable with ventilation just yet. As you get more comfortable with the patient, you can widen out your alarms. We're always conscious in the back of our minds of those basic principles of delivering the lowest amount of oxygen possible. So don't be afraid to wean your oxygen. We're aiming to reduce the work of breathing. We're aiming for control of that PaCO2. All patients who are ventilated in Australia and New Zealand now need to have their end-tidal CO2 continuously monitored. So yes, we're taking blood gases often to monitor and titrate things, but we need to be continuously monitoring their end-tidal CO2 as well. By controlling the person's CO2, we're maintaining a normal pH for them. We're conscious to do no harm, so we're avoiding those high pressures, particularly high plateau pressures. And as soon as possible, we're thinking at all times does this person still need to be intubated? Okay. The longer we leave people intubated on a ventilator, the more at risk they are of developing infections. And there is a really, really well-known phenomenon called ventilator-acquired infections. The longer you're on a ventilator, the more risk you have, basically, of developing a chest infection because of being on a ventilator. There are other really key terms like resistance and compliance, but for the purposes of basic ventilation, we won't go into that because what we've covered today so far should really set you up pretty well to look after a person on a ventilator in the first instance. So in conclusion, terminology, I think ventilator companies are pretty good at confusing us with fancy terminology, but I think ultimately if you can pin them down to thinking, is this a volume control, a pressure control, or a pressure support type mode of ventilation, you'll be able to work your way through that 9 times out of 10, okay? So having a good grasp of some of these key terms we've covered today will really set you up in good stead to have these conversations with people when they're talking about a new particular mode of ventilation that you may not have heard of before. I promise you it's probably going to come back to some of these basic principles, and if you can understand that, you'll be fine. It very rarely matters between choosing volume control or pressure control because you're delivering one and monitoring the other. And main thing, avoiding harm, okay? Any patient that's ventilated needs to be constantly observed. You know, our patients are at risk of waking up all of a sudden. No one likes a breathing tube in their mouth or in their neck if they've got a tracheostomy. And very often they're going to want to get that out or wake up and think, what is this? People who are ventilated need constant observation. We're mindful of our lung protective strategies. And we've talked about getting that breathing tube out as soon as possible. Thank you very much.